Chicago. And I must apologize for two things. First, for leaving during this session, but my jet lag is really getting in the way, and I either have a Whipple disease and hypoglycemia, or I really had to get something. So apologies about that. But also for the title that we put together for Sam, and I must bear responsibility for this, but it's really out of self-interest, and I think several of you are in the same situation. Like, what do we need? What should we look for? And I can see in the audience, it's probably maybe a quarter of us that have access to robots. So potentially the 3/4 are still looking at acquiring one, and what are the things we should be looking for in terms of team training and what to buy, etc., what's on the horizon in terms of perhaps alternatives to Da Vinci. So Sam, thank you for accepting our invitation to speak about this.
Thank you, Mark, and thanks to Jean-Luc for inviting Eric to give this talk, and Eric asked me to pinch hit. So I put together some slides. I've started a couple of robotic programs in my time, 3 in my previous practice in Milwaukee, Wisconsin, in the United States, and more recently at the University of Chicago since I moved there in the summer of 2013. And I'll try to present some useful information for those of you who are interested in starting a robotics program, and it'd be a nice platform for a discussion about the role of robotics in cardiac surgery in general, because I think that's an important issue for us here at the ISMICS Society. These are my disclosures. I accompanied them by a graphic from a French comic that was drawn, believe it or not, in 1914, and how the artist envisioned the operating room in the year 2000. And so many of us did not realize this in 2000, except for some, like Johannes maybe. But I started robotics in 2007, and so I was about 7 years late to this actual vision. So Mark was very inventive in putting together the title for this talk, and so I try to address each of the topics of the title with a couple of slides. What to buy? Well, at first you need a robot. The only robot that is available to use in cardiac surgery is the Da Vinci robot. They have rolled out their latest generation, which is the XI, and as you've heard in the previous discussions, that XI does not support coronary work if you want to do it on the beating heart. And when you talk to Johannes, who does a fair bit of arrested heart TCAB, he also believes that the stabilizer is necessary for arrested heart TCAB, and I can vouch for that. I use the stabilizer for a lot of robotic surgery. 90% of my surgery is done robotically, and the stabilizer is extremely important for things like pericardiectomy, for AFib ablation, for obviously TCAB, for lead placement, and various other things. So I think the stabilizer, what we need is momentum from a group like this who is interested in coronary surgery, or from a group who is interested in robotic heart surgery in general, to really make a stand to the company that the XI, which is the latest version of the Da Vinci robot, requires a stabilizer. It is a very versatile instrument. It is extremely important in what we do, whether it's on the beating heart off pump, or it's on the beating heart on pump, or if it's on the arrested heart, as we saw Johannes working on the back of the heart with the help of a stabilizer. So this slide basically summarizes, I have a picture of an SI, but the XI is very versatile, and to answer the question from the audience a little earlier, there is XI work being done on the mitral valve. Sloan Guy at Cornell does that a fair bit, and I think I know of somebody else who has an XI that's using mitral valve, doing mitral valve surgery with the XI. And it lends itself extremely well to quick docking, maybe moving from one side of the chest to the other. The colorectal surgeons and the chest surgeons, they're the ones that like it the most because it has 4 quadrants. And so in terms of deciding which system you're going to buy, it really depends on today what you are doing. If you're going to use it for TCAB, if you're going to use it to advance your coronary minimally invasive practice, then today the stabilizer is not available for the XI, and you must get an SI. Simulation programs are very important to purchase at the same time, because that's going to get you into practice, get your fellows into practice, spend long nights in the laboratory during simulation, and that's a huge boon to robotics today, which was not available 5 and 10 years ago. And I think those programs have come a long way from just skill simulators to actual procedural simulators that can be very useful. New robots are on the horizon. I don't think we're going to see any of that in the next 2 to 3 years. Google, J&J have a company called Verb that is developing a robot. We're trying to engage them in cardiac surgery. Medtronic is also developing a robotic system, and SSI, another brand new company that I think has a lot of potential to move this field forward. Facilitating technologies are extremely important if you're deciding to use robots. I liken the robot to a piece of hardware that unless you have the appropriate software for it, you will not be able to use it. So buy a computer. If you don't have the software, you can't do much. What is the software in this case? If you're doing, in my mind and in my practice, multi-vessel, totally endoscopic beating heart coronary bypass, I think an anastomotic device is a very important piece of software. If you're doing arrested heart surgery, as we saw before, peripheral cannulation, endoballoon, and those types of technologies are very important to acquire. Here's the top 10 reasons, or 12 reasons, that cardiac robotic programs fail. And I've highlighted a couple of the ones that I think are extremely important. The first one is inadequate surgeon training. And it's very important not to take the notion that you can go watch somebody for a couple of days and come back and do your first TCAP, or come back and do your first totally endoscopic mitral. That is not going to work. And I'm part of a task force for the STS that is trying to figure out exactly what is the stage and what is the skill level that's required for a surgeon to adopt robotics. Is it like me, who maybe 10, 11 years into practice and having an extensive amount of experience with minimally invasive surgery decided to do robotics? Or is it somebody who just finished their cardiac surgical fellowship and decided to go spend a year with Randy Chitwood or go spend a year with Johannes and then evolve into a robotic surgeon? The answer to that is still not clear, and I think it's important that we address it in terms of where and when and how long training of the surgeon is required. Inadequate team training is extremely important. I think that's self-explanatory. Support from the program is required by some of the particulars and the principles in the hospital, and we'll talk about that. But the second, I think, most important reason that a robotic cardiac surgery program fails is lack of a dedicated and a consistent operating room team. And it's very important if you're starting your program or you're in the middle of your program and you're not moving forward, is to demand that you have the same people every day in the operating room that are doing your cases, because there is no substitute for the experience and the training that comes with consistency. Inadequate case volume, whether it's mitral or coronary, poor leadership and communication skills, we all know what the results of that can be. Unsupportive team members, and whether we're talking about the anesthesiologists, the nursing staff, or the perfusionist, if you don't have buy-in from the various members of your team, robotics will not work at your hospital, and so that's extremely important. And there are a couple of other things here that you can talk about. Poor case selection early on in your experience is another one where people can get into the wrong case and maybe take on a little bit too much in terms of a challenge and then have a problem executing, and that can be a killer of the program. This is a slide, and a lot of this talk is actually borrowed from Sloan Guy at Cornell, who talks about the 5 families, and I think that's becoming a term that we use a lot. If you've ever seen The Godfather, the 5 families, you have to have buy-in from those families. It's administration, anesthesia, nursing, perfusion, and surgery. And any lack of enthusiasm and or commitment from any of those 5 families can be very, very detrimental. We have a lot of buy-in from pretty much all of those families in our program, and we are able to do a big number of robotic cardiac surgical procedures. We probably do about 170, 180 cases a year of all different varieties, and we can talk about that aspect of that as well. One of the things that I like to pride myself, and I saw Johannes' video about the docking of the robot. One of my anesthesiologists is very keen on docking the robot himself. And I've taken some videos of that, and I don't have them now, but we're very proud when he comes in and he does the case. The attending anesthesiologist docks the robot himself, and he's probably the fastest docker that we have. Dedicated robotic heart team, I think, is extremely important, and many of you who do special kinds of procedures like TAVIs, or you do minimally invasive heart surgery, or anything that's kind of out of the ordinary, even cardiac surgery, when you really think about it, is out of the ordinary. It's not regular surgery, and if you don't have a dedicated cardiac surgery team, you're under the gun and maybe behind the 8 ball in terms of having great outcomes. But it's high-performance, interdisciplinary teamwork. It is absolutely essential to have a safe and a successful program. And I call that a consistent tableside assistant, at least 1 or 2 consistent scrub nurses at the table, and 1 or 2 circulators who know exactly where everything is. You don't have to waste time, valuable cross-clamp time in terms of trying to get things. And I maintain that the complex teamwork that's required for these procedures will generally improve the cardiac surgery teamwork overall in your cardiac surgery suite. And this is a picture of our team to the right in the operating room, kind of manning the robot, and to the left a couple of nights ago in downtown Rome. So some of the prerequisites, depending on whether you're looking to start a coronary program or a mitral program, volume is extremely important. You can't start the robot thinking that you're going to develop volume. I think it's important to have volume to begin with. In coronaries, I prefer that somebody be experienced with OpCab to be able to do some of the maneuvers, to be able to have the communication skills with anesthesia. I think that's an important aspect. We, in the OpCab world, we developed many years ago the ability to talk to the anesthesiologist and not to put our head down and sew, but to actually look at the hemodynamics and be involved and talk about the drips and what we need to change and how we need to work and maybe bring the heart down a little bit. So those skills are very, very necessary if you're going to do beating heart TCAB. You need support from the heads of the 5 families. Anesthesia needs to be very versatile in single lung ventilation, and you as the surgeon need to know what it means to insufflate the chest with CO2, because there are some hemodynamics and physiology that happen during the insufflation process. You need to understand maybe if a patient has COPD, you can actually do 2-lung ventilation once you establish domain in the left chest and continue the procedure. Calm demeanor, extremely important in whatever we do. And I think when you're starting the program, it's important to get a dedicated operating room with a robot at least twice a week so that you can continue and evolve in your program and not have to fight the urologists and the gynecologists, and get it maybe once every couple of months. That is not the way to start a program. If you're starting with mitrals, you need to be an experienced mitral valve surgeon with your 2 hands before you start to invoke the robot. You need to have experience with minimally invasive valve surgery, peripheral cannulation, endo balloon, Chitwood clamp, whatever it is that you do. Evolve your minimally invasive approach without the robot first, then move into robotics so that your learning curve is not complicated by a lot of different things. Support, again, from the heads of the 5 families. Anesthesia, in this case, needs to be facile with transesophageal echo, obviously, with the special line placement, CS catheters, and whatnot. And again, calm demeanor, very important. This is just a repeat of what the team brings to the table and how the interaction with the team can be and should be. Everybody needs to be able to be delegated to what they do best. Don't try to micromanage the perfusionist. They have to have buy-in. They have to have your back, basically, and you have to trust them to make the right decisions. No blame games if something goes wrong. There has to be feedback and openness. All those things that we all know that are necessary to execute any special type of a program. Some of the common pitfalls is that you really are trying to learn too much at the same time. You don't have enough volume of whatever procedure it is you're trying to do. If the junior partner is assigned and they don't have experience in open surgery and they are relegated the development, and I see this a lot, they're relegated the development of this new robotic program, that is a recipe for failure unless they have a supportive senior partner who is going to be able to guide them through, maybe be their tableside assistant for a significant amount of time, and to have them take some of their volume and allow them to progress. And so I think that's a major problem. And then it is a challenge, and if you underestimate the magnitude of the challenge, then it's not going to work out. So the template for success: consistent and dedicated surgical team, a surgeon who is facile with minimally invasive surgery, a good communicator, has patience in addition to all the other skills, The bedside assistant is extremely important. We didn't talk about that a lot. I have a physician assistant as my bedside assistant. She's excellent. She's had 7 years of heart surgery training, and now she's been with me for 2 years, and she runs the operation like a pro. Some people prefer to have a surgeon at the table, which is also doable. That person needs to be communicative as well. Administration has to have a lot of support with equipment and training of the personnel, with buying all the things that you need. They need to refrain from early or premature marketing of your program, because this is not the way to get cases. It's not the way to compete in the marketplace. It is a way to do the right thing for the patients, and if you do that, then the market issues will follow. The operating room nurses, the techs, they need to be dedicated as described. Anesthesia we talked about, and perfusion are very, very important. So the bottom line, you need to really honestly assess your pre-robot program. Are you there yet? Are you ready? Is the team ready? Do you have buy-in from all the people? Surgeon training obviously varies depending on what you've done and where you fall into the learning curve. Team training is critical. It's very important when you're embarking on this to do some mock cases, to go through dry runs as many times as possible. Take your team to an experience center, watch what they do, take notes, learn, maybe go a couple of times, but definitely bring the team. Use the robot for as many procedures as possible. You can do a pericardial window with the robot. You can do an epicardial lead placement with the robot. You can do an AFib ablation with the robot. Try to think about what the different procedures that you do in your practice are and what can lend themselves to robotics. And every one of us has a robot in their hospital. You probably don't know the access to it or how to get to it, but I guarantee you that unless you don't have urology in your hospital, you probably have a robot. It might be an older robot, and that's where the conversation begins as to what system to use. I think I'm running a little bit over, but this is a little diagram that kind of talks about some of these concepts that we discussed. I think taking it slowly, doing a lot of reflection and self-assessment, continuing to choose dedicated team members is extremely important. So I think I'll stop there, and thank you very much. Come see us in Chicago anytime.
Sam, that was very insightful. You can see a number of people, including myself, who took pictures of your slides, because I think many of us in this room, which is wonderfully engaged, we've had no breaks, and all of you are still here. It's wonderful. Really, congratulations. Stay tuned, because we have 3 10-minute talks left. 2 very quick questions. One, can you still buy an SI? Will Da Vinci sell you an SI today? And second, a mock case, how do you do that? Just give us maybe a 30-second, like what's a mock case at your own institution?
Yeah. So the first question is, does Da Vinci or does Intuitive still sell the SI? And the answer is yes. You can get a refurbished SI for actually a pretty cheap price, so it's a deal, especially if you're totally devoted to coronaries. Now, it's kind of like buying, last year's computer or last year's laptop. So if you're not going to buy one for another year or so, give us a little time, and we're still trying to really put some pressure on Intuitive to bring the stabilizer for the XI. The second question, a mock case, depending on the procedure, if you're looking at doing a mitral valve, then you bring a pig heart, you put it in a chest cavity, you dock the robot, you do everything as if you're going to do the real case. So you have all the instrumentation available, you have all the things that you need, the team knows exactly where everything is, and you do it from A to Z. And if you do that, 5 or 6 times before you do your first case, I think you'll be in good stead. If you're doing a coronary, depending on how you're going to do it, pretty much the same concept.
Super. Thanks so much, Sam. Half an hour left. 3 excellent presentations.